by Dr. Mohanty, and you can compare the problems which we each have in treating patients. So this is my medical college hospital, 2,000 bed teaching hospital, several specialties are there, and this is the cancer center where we treat cancer patients. We also have 2 transplant rooms in the corner here. And this is my city, the big city of the world. So if you ever come to this part of the world, please be aware that you have a friend there. And I'd like to just quickly tell you that we are doing the first Indian Cancer Congress in November.
Consolidation alone. And we also can put in both induction, consolidation, or maintenance. So the total dose, the total number of cycles are different. The way of giving drugs are different. So even though I think the concept of upfront arsenic is well established now, I can say.
In hypoidentical transplant receptors. However, severe GVHD might be comparable. Of course, research with a better design might further need to further confirm this result. Then we try to compare the relapse rate to the unknown relapse rate mortality. This is the data published in Leukemia. It seems that the relapse rate in hypoidentical transplantation was significantly decreased compared to cord blood. Also, non-treatment relapse rate decreased, but non-treatment related mortality was no significant difference.
It seems to have less relapse, but it also has more non-relapse mortality. And so in the end, you have basically similar results with different complications, depending again on the donor. And then this is very recent data. This is this isn't published. This is data that Colleen Delaney and Filippo Milano from the Hutch presented at ASH, comparing the Fred Hutchison Cancer Center cord blood results. These were acute leukemics in remission. And you can see here, very impressive. These were younger patients. The median age, I think, was 48. Patients all got TBI-based regimens, but you can see very favorable disease results for cord blood compared to their, and they're not statistically different, but quite promising.
Pattern of lymphoid infiltration or differential diagnosis of granulomatous pathologies and so on. Chairpersons, please remind me 5 minutes earlier my time. So I'll show you some examples. This is a hypocellular marrow on the left side and there also. So the degree of hypocellularity is variable compared to this normal cellular marrow for a given age of the patient. So if you have hypocellular marrow and primarily 3 differential diagnoses, primary hematological disorders you have to keep in mind to begin with: aplastic anemia or hypocellular MDS or hypocellular AML.
In another center in Hong Kong, and in the literature it's around 17%. So it's still an issue. So the 4th generation probe is actually a tricolor probe. Okay, here we still have the large probes spanning the ABL and the PCR, okay, but on the ABL side, on the chromosome 9, okay, there's an addition of an aqua probe, okay, so tricolor, green, okay, orange, and aqua.
Has a compound ABL-101, which used to be the Avila compound, which is slightly different from this pharmacyclics in that it binds very heavily with covalent binding properties, so it might be a tighter fit. And what that means is that whenever you give the inhibitors for BTK, you look at the occupancy of the drug at the site, because the signal propagation that happens downstream of the BCR is dependent upon this BTK. The longer it binds, the better the inhibition is. So these are all the BTK occupancy as one of the pharmacodynamic effects that were seen. And I believe that the AVL 101 has much stronger properties from the volunteer studies and very early data. Examples of the 17p deleted patient disappearance. Won't talk much about sick because the company is now trying to develop only in diffuse large B-cell lymphoma. But the first, I don't know if you recall, Jonathan Friedberg had a plenary session presentation, and he showed data on CLL responses were seen at CLL.
So I thought I'll give you an overview over its mode of action, what it distinguishes from rituximab, and then we touch upon some phase 1 and phase 2 data, and I give you a rationale for the dose selection that we are taking forward. And in the end, I would show you the full program of clinical development. We currently have about 14 global studies running with GA101.